welcome to this webinar of the Jerusalem Press Club, JPC, another one in a series, Israel is Alive and Kicking, with the team of Sheba Hospital, who will update us with their latest accomplishment fighting the coronavirus. I would like to thank Stephen Walz, head of Sheba International Media Relations, for making this webinar possible, and I would like him to introduce the speakers and to moderate the session. Steve, please.
Thank you, Uri. We're going to have a very interesting session today. I know that there's been a lot of curiosity about Sheba being in the headlines from day one, not just in Israel, but all around the world. And I can say that I have enough information for actually 3 or 4 press conferences, but we're going to focus on a few issues today, with the headline being pissing off COVID-19. We've pissed off COVID-19 from way before COVID-19 even appeared in Israel. I want to take you quickly through the timeline and some of the first in the worlds that we've done. And then I'll introduce our 2 guests today who have been directly involved with Sheba. Professor Douek from the National Institute of Health, who was actually in Israel, and also the CTO of AnyVision, Neil Robertson, who will speak about some of the technologies that we're using here to defeat and actually piss off COVID-19. So very quickly, the timeline is as follows. Even before Sheba had the first patient to deal with COVID-19 in January, we knew already that Sheba would be on the front lines of the battle against COVID-19. We were already drilling and already preparing for it. The first patients we received were on February 21, when we received the Diamond Princess passengers, the Israeli passengers who were stuck on the Japanese ship for quite a while. Several of them tested positive for the coronavirus, and we took it from there. And then, of course, things started to scale up here as far as the corona patients are concerned. Understand that from day one, Sheba was in contact with all of the governmental agencies, since the governmental agencies had asked us to take this national mission upon ourselves. And therefore, we created several firsts in the world. The first coronavirus unit, which was off campus, about a mile from the main hospital building, then on to using the telemedicine programs that were also first in the world during the first course and throughout COVID-19, on to the first psychiatric corona unit, which is still gathering headlines around the world for psychiatric patients, and on to the maternity ward for COVID-19 patients who were in labor. And also we were able to build an underground unit, critical care for COVID-19 patients within 72 hours, which is basically impossible to do for other countries around the world, including the United States, because in Israel, as you know, we are always in a war environment, and therefore you have to adapt and be agile. And Professor Yitzhak Kreis, who is the CEO or the Director General of Sheba, had told several members of the media that one of the reasons we were able to do the things that we did, as opposed to the United States and other countries, is Israel's ability to be agile and to adapt as things happen. So first, I also, before I go into other headlines that we're doing here, I'd like to start with our first guest, because I'm sure you have a lot of questions for him. Professor Daniel Douek from the National Institute of Health, he's the chief of immunology division for vaccine research at NIH in Maryland, but he's based here in Israel at the Weizmann Institute. The NIH has signed a specific agreement with Sheba Medical Center to try and accelerate all of the research in trying to find cures or a vaccine for the coronavirus, and also the proper treatments going forward, because as you know, Sheba has pissed off COVID-19 by battling it to a draw right now, but that doesn't mean we're not going to get a second or a third wave. So Professor Dweck, the floor is yours.
Thank you very much, Steve. It's a pleasure to meet you all. I should say that I'm here in Israel on sabbatical. I'm Chief of Human Immunology at the Vaccine Research Center at the NIH. And most of what I do is HIV work, and I've done that for a long time. And I came to the Weizmann to study cancer. I wanted a little bit of a break, and I thought it would be fun to study cancer at the Weizmann Institute. And little did I suspect that I would end up in the middle of a coronavirus epidemic, running my lab here at the Weizmann and my lab back at the NIH. And it was through contacts in the HIV field that I made contact with Sheba initially. The project that we've started with Sheba, I think, is quite remarkable and quite unique. I think it's best described threefold. The first is to establish predictive correlates of disease progression. And simply, what does that mean? It means that, as you well know, you have people who are infected and are asymptomatic. People are infected and have a mild infection, severe infection, some people who end up in hospital, and some people who end up dead. And we want to try and understand why people have different, or how people have different disease courses. And we do that by partnering with Sheba, getting samples of blood and other tissues from their patients, and we try to match the measurements that we make with the clinical outcome of these patients. And importantly, we're also doing that in some of the therapeutic approaches. You might have heard of some of the drugs that are being used to treat severe COVID infection, to try and understand how some of these therapeutics might mitigate the outcome of the infection. So that's number one. Number two is we're working with Sheba to look at the people who are convalescent. That is, people who've become infected and then who have survived the infection. So obviously they've done well. And we are interested in looking at why those people have done well and identifying antibodies that can be used as therapies. Now, you may have heard of monoclonal antibodies that are being discovered to be used as a therapeutic agent against the virus. We identify these therapeutic antibodies from individuals who've recovered from the infection. And so we're doing that as well with the convalescents. And finally, there's a really critically important question, which is that if you've been infected and you've survived and you've done okay, are you immune? Are you immune for reinfection? And if you are immune, how long does that immunity last? We don't know the answer to those questions at the moment. And so this is potentially a collaboration that will go on for quite some time with Sheba, that will follow these individuals over time and will try and understand how immune they are and how long that immunity lasts. So that's where I'll put it for now.
Thank you, Daniel. If there are questions out there that would be directed to Daniel, now's the time to do it. Any questions for Professor Dweck? Okay, so let me just continue along here and add to what Professor Dweck has said. Many of you have been reading about these particular antibodies and the research that the Institute for Biological Research has been getting a lot of headlines in the last few days, that they're on course for perhaps a vaccine through the antibodies and everything. So you could understand that all of the blood plasma, all of the viral, the coronavirus itself and the blood came directly from Sheba to the Institute for Biological Research. In other words, without the biological research and the materials that come from Sheba, they wouldn't have the materials to work on what they're working on now. I understand there's a question out there for Professor Douek from Yana.
So which answers have you managed to make progress? So to the first answer, establishing predictive correlates of disease progression, it's becoming clear in the field that if your immune system loses control of virus replication, so your immune system comes in and it tries to kill the virus, if it's not able to do that soon, then what happens is the virus replicates in an uncontrolled fashion, and then you get what you might have read about is what's called a cytokine storm. And that's your immune system going absolutely nuts, producing all of these rather toxic compounds, which in a controlled fashion are good because they control the infection, but in an uncontrolled fashion cause leakage of your blood vessels, they can cause clots in your blood vessels, and eventually they can lead to death. So the first, we're beginning to get answers there. In terms of convalescent samples, we're going to ship some blood to the lab at the NIH, and we're going to be sorting cells and identifying antibodies in much the same way that the Biological Institute has been doing it with Sheba samples over the last month or so. So that will come soon. And follow-up immunity, I think that's a project that's going to go on for 1, 2, perhaps even 3 years.
Okay, and if you see some of the other questions here, have you managed to learn the lessons that might help if there will be a second wave? Does anybody really understand how each country is dealing with the second wave and what the DNA of those second waves might be?
Have you managed to learn lessons that might help if there will be a second wave? Yes. I think, I mean, I'm speaking now not as a scientist, but I can speak on behalf of clinicians, is that certainly preparedness, because we know how many people need to be ventilated, we know who needs oxygen, we know that kind of thing. We know that it's not only old people who get the infection and do badly, some young people can do so as well. So in that sense is clinical preparedness. You may have read in the papers about the drug remdesivir, which looks very good in terms of a treatment. We know that the body generates neutralizing antibodies against the virus. These are the antibodies that we're trying to identify. And there are plasma donation schemes that are being instituted all over the world, such that hyperimmune plasma can be given to infected patients. So if there's a second wave, I think there's a lot of preparedness, clinical preparedness, therapeutic preparedness. As you've heard Dr. Fauci say on a number of occasions, a vaccine may not be ready until sometime next year, but there's a number of therapeutic approaches that can be adopted in the meantime.
Okay. Okay, so you see what Yana wrote, knowing what you now is illness and mortality. Would you say the policy adapted by Israel was the correct one? I mean, regarding the total closure.
So I'm a bench scientist, and I'm a bench scientist at the employed by the United States government. So I don't advise policy. I'm not allowed to, and I can't say whether it was good or bad or anything like that. But I can say that the steps taken was sensible, and I would say that the fact that Israel is opening up a little bit now is probably a testament to that. Nevertheless, I walk around with my mask everywhere. So again, reiterating what Dr. Fauci said in his when he gave testimony to the Senate last week, I think one has to be humble in the face of a virus that one doesn't understand fully and that one can't predict.
What do you think in terms of your experience here the last few months regarding the National Institute of Health actually does a lot of work with Sheba over the years on a lot of other areas that are not your areas of expertise, but we do a lot of work with the NIH. What has surprised you about the way things work here in Israel and the cooperation, not just with Sheba, but in general? Is there a general difference between the way Israelis work and the way the Americans work in dealing with something like this?
I wouldn't say it surprised me because I knew about it already, but there's an amazing ability in Israel to come up with really clever solutions rapidly on the fly and without much funding. And I think that in some way comes from the fact that there's not huge amounts of money like NIH funding here. You know, I came to Israel to do my sabbatical, not because the machines are big or because there's tons of money or anything like that. I have bigger machines and more money at the NIH. I came here because the people are super smart and extraordinarily inventive. And that's what I've enjoyed here, is that in a matter of weeks, people at the Weizmann Institute, who are not even virologists, have thought of extremely innovative ways to combat this infection. And when I approached Dr. Itzik Levy at Sheba, and I want to reiterate, this was because of my connections in the HIV world. So I'm used to doing this. HIV scientists, we've been reaching out across the world for the last 20, 30 years. So these kind of collaborations, this is my life. But when I reach out and I said, can we collaborate on coronavirus? It was within a week, within 2 weeks, everything was sorted out. Everyone was willing to help to get this done. So I've been delighted rather than surprised at the enormous amount of innovation that I find here and the ability to get things moving really, really rapidly.
Thank you. I understand that Paul Martin is asking, are either of us getting outside investment into the program? Well, the NIH is a part of the United States bureaucracy. So, money comes freely into the NIH for whatever I guess you guys need. And from our point of view, Sheba is a complicated institution. It's a national institution. It is a national hospital, but there are many subdivisions here that do get either donations or outside investments. For argument's sake, our ARC Innovation Program is the only hospital in Israel that actually has its own VC fund, but it's an outside VC fund in the name of Sheba called Tri Ventures, where they actually invest in some of our startups here, some of which we hopefully will be used towards solutions regarding COVID-19. So, it depends on the type of thing that you're investing in, but Sheba as a National Hospital of Israel has its own investment arm for its innovation programs. Any other questions for?
No, I would add that, for my funding comes from the United States government. So I'm an intramural investigator at the National Institutes of Health. So this collaboration, and in fact, my sabbatical, I'm doing it as an official duty for the United States government.
Okay. And one last question for you, Professor Dweck, is I see here from Janet, is what the most serious challenge is in dealing with the coronavirus? That's $1 million question.
Oh boy, the most serious challenge in dealing with coronavirus, I think we have to have a vaccine, really do. Herd immunity at the moment is not terribly high. A lot of people have become infected, but it's not high enough that we can rely on natural immunity from people who become infected. So I think the highest bar, the most serious challenge is that we have to have an effective vaccine as soon as is safely possible.
Thank you, Professor. I'd like to now move on to our next guest. And Professor Douek, if you want to hang around for a little bit in case there are other questions. I'd like to introduce Neil Robertson, who is the CTO based in the UK for AnyVision, which is one of the super advanced technologies in dealing with COVID-19 that we're using here at Sheba in terms of identifying people who might not wear masks. Uri, do we have the video that I sent that people could actually see what AnyVision is about?
Yes, we'll run it right away.
Let's run it and then we'll go from there.
Thank you.
So.
No sound?
No sound. No, we don't seem to have sound on that.
Okay, maybe I could add a bit of voiceover while it's running. What you're seeing here is some of AnyVision's core technology programs in safety and convenience. I'll elaborate on this a little bit more. The examples that are coming up here that you're starting to see are in seamless access control, contactless entries to buildings, and the use of recognition technology for authentication and security, where your face is used as a significant factor for maintaining privacy and security in access to services, particularly banking apps and internet level security. You want to keep going there with it? Yeah, so this is access control, which is robust to whether somebody's wearing a mask or not, and that's quite unique in the world of recognition. And this is the ability to match people within visual context within cameras while maintaining privacy, i.e. the face information is not actually stored, and this is anti-spoofing technology. And this is just some images of our research team, which is based in Belfast in the UK, where I lead as the co-founder of AnyVision. I lead the R&D effort, which actually builds out these systems. So that's a rather ad hoc voiceover. I'll just give you I'll give you a better introduction, and perhaps we could post a link here actually to that video within the comments, and people could view it later. Okay, so let me just introduce myself properly and give you the quick 3 points about what we're doing with Sheba and why this is important. I'm a professor of vision systems at Queen's University, director of research, and one of the UK leaders in machine learning. I also am co-founder of AnyVision. AnyVision is known for its real-time, real-world recognition technology, and we are focusing on markets particularly around safety and convenience, and that's the applications that you saw there, where essentially the face becomes the ability to access physical infrastructure and services securely, and that's based on our core IP and our core algorithms in computer vision. Computer vision is the science of making machines see, so it's providing intelligence into the physical and computational network. What are we doing with Sheba? We are, in a nutshell, using our recognition technology for improving contact tracing. And one of the issues with contact tracing that we're seeing around the world is that it's a voluntary system. Certainly the apps in the UK, don't know about the US and further afield, require information to be uploaded by the user, and there's significant blind spots within the mobile network. How do we improve this? In Sheba, there's 150 existing cameras in the hospital, and we're providing the AnyVision system in order to make the place safer for staff who work there. Essentially, what this means is that we've created a number of new technologies on top of the existing and provided it to the hospital itself. In particular, there's an association feature which shows people who are in close proximity with a known infected person for a duration of longer than a set number of minutes, and that can be adjusted by the users, by the staff in the hospital, typically 10. And this can be achieved in aggregate across all the cameras. That means that when an epidemiological or clinical investigation has occurred, a nurse or another authorized user, a healthcare professional, can search backwards in time through all of the CCTV network within the hospital and identify who came in contact with that infected person. And there's strong evidence that this then helps limit the spread of further transmission. And the advantage here is that these are known people, because that's the power of AnyVision technology. You can match to known individuals, and it's done within the context of a circle of trust in the hospital, and it's for employees. So there's no random picking up of individuals who happen to be patients in the hospital. And I must stress, this is not a forward-looking piece of technology, so there's no active surveillance of people. It's done only under the authorization of a nurse, somebody in a position of trust. The second technological innovation here, which is significant, is that we've improved our underlying system to work in order to recognize people with masks. So you would assume that it's harder to recognize somebody when they're wearing a mask. In fact, computers are very adept at discovering what's the important information within the facial structure, even if it's partially covered. And we've developed a new science and new algorithms in order to achieve tolerable recognition of people with masks on. And we also use a full body detector so that the person can be more robustly identified even when they are occluded in the course of their day job. And that's another thing to underline here, is that this system is fully hands-off and doesn't interfere with the everyday working of anyone within the hospital, so the clinical functions of the hospital go on unimpeded. And actually the third innovation, which is important, is that as a function of being able to recognize people with masks, people without masks and with masks can be identified as a class. So if there's a situation where somebody is not adhering to the PPE regulations, unlikely, I know, in a world-class hospital such as Sheba, but as we roll this technology out across the world to help businesses reopen and to help safeguard people, this is an important feature to be able for people to feel secure that their colleagues and visitors are adhering to PPE instructions that keep them safe. So that in a nutshell, I'll wrap it there as the intro, and happy to take any questions about how we're using this technology.
I'm gonna start that with you, Neil, because as someone who saw the technology being shown last week, I'm curious to know, as this technology is being rolled out at Sheba, people don't realize how many people at Sheba actually pass through this hospital every day. We have 20,000 vehicles carrying people who need various treatments and patients every day. That means tens of thousands of people, including the 9,200 workers that pass through here every day. So we're talking tens of thousands of people who go across this campus, 200-acre campus. What has been the biggest challenge for you, and what have you found within the realm of using this in this period where Corona has basically overtaken most of the campus philosophy at this point?
Yeah, so we started off in a strong position because the unique features of AnyVision are its scalability. And this actually also relates to privacy. We don't get overwhelmed with massive amounts of data because of the way we encode the facial structure. Actual images of faces are not passed around in the computer network. They're encoded into small vectors, which are secure and also lightweight. And I think that's one of the really interesting aspects here, is that no matter how overwhelmed, if you like, in, say, in inverted commas, the hospital was to become, technology like AnyVision provides an ability to continue working through these large numbers, and also doesn't suffer from fatigue or inaccuracy due to overwork. And I think that's really opening the door to say that, look, while we appreciate people, we have to show that facial recognition is a trustworthy technology. This is a perfect example to show that it really doesn't suffer from some of the problems of data deluge that might occur in legacy technologies.
Mm-hmm. Okay, if there are any questions out there, please send in the chats now, because we'd like to move things along. Again, AnyVision is one of the unique technologies that we are integrating here at Sheba that will deal with the issues of Corona and other issues that will come up along the way. It's not a singular event that we're dealing with here. AnyVision will be integrated into the regular operations of the hospital, not just here, but around the world. AnyVision is already selling this technology in other places around the world, and it is unique because it will change the way hospitals operate in this new era. And I would have to say, Neil, that Corona has actually made us, pushed us 5 years ahead in terms of dealing with technologies that will be integrated into hospital systems. So would you say that, would you agree that in the Corona era, hospitals that were thinking about new technologies 5 to 10 years down the line have actually been able to push that technology faster into their systems, and actually in 2020, something that they thought maybe would be integrated in 2025 is something that is being integrated now because of Corona?
Correct. I mean, I'd echo Danny's comment also that there's an amazing go forward within the Israeli community, and that's one of the wonderful things about working. We have our HQ in Israel, and it really has allowed us to to work at a faster pace because of the inventiveness there. But I think the important point here is that people recognize that there are privacy concerns around face recognition, but businesses, hospitals, and individuals have a responsibility also now to wider society to protect their fellow man. And I think the wonderful thing about what we're doing here in Sheba is that we can demonstrate the efficacy and power of modern computer vision, but do it within a context of genuine trust and care. And really that sort of partnership can be a game changer for the adoption of new technologies, where perhaps there used to be caution and potentially some anxiety. Now it's clearly repurposed and moved towards applications that build trust and health, maintain health. That's significant.
Okay, and what I think what people who in the media should understand, that the scope of Sheba's investment in trying to deal with the coronavirus, I'll give you some interesting statistics. To date, Sheba is the only hospital in Israel that's treated the most patients when it comes to corona. We're up to about 450 patients. That's more than any other hospital in Israel. As of yesterday, we were down to about 37 from a peak of about treating 115, which is a remarkable progress and shows what's going on out there. It's also one of, AnyVision is one of 183 different projects that Sheba is involved with regard to discoveries and research with regard to dealing with the COVID-19 challenge. So I think that it's important for people to understand that Sheba is a tremendous test bed for all new technologies, medical innovation. And I think it's important for people to understand where we're at and the people that we're bringing in from all around the world to try and help us deal with the coronavirus. And Paul Martin has a question for you. Neil, it says...
So the question is, Neil, you're from the UK. Is it being tried out in the UK yet? I think to my last point, that there's an admirable sense of getting things done in the Israeli community that isn't always reflected in sort of larger countries with bigger, more nationalized infrastructure. We are working locally anyway with the Ulster trusts in Northern Ireland to try and demonstrate the power of this kind of technology. But I think it's a case of going as fast as people are comfortable with, and we will continue to show what can be done and be ready when the time comes for adoption on a national scale. So,
okay.
Fingers crossed.
The question about the peak numbers, let me take you through that a little bit. As I said, Sheba had jumped into the war against the coronavirus on February 21st with the first passengers from the Diamond Princess. The peak was in April, where he had reached 115 corona patients in various conditions, from mild to severe, or what we would call critical care. What had happened over a period of time is that a lot of the patients that were originally light corona that we had originally taken on were moved to home care. And home care has been basically where most of the people have gone now. And that's one of the areas where Sheba excelled with the telemedicine. You should understand that telemedicine is now being used outside of the campus, and where people can actually take care of themselves at home and be in contact with their doctors through their cell phones. Again, moving technology 5 years into the future, into now, turning back the clock and using it in 2020. So you should know that telemedicine is being used to take care of most of the mildly ill corona patients, so that the hospital, whether it's this hospital or any other hospital in Israel, can take care of the moderately ill and the critically ill patients. And I can also bring you another headline today that on the Doctors Only website in Israel, which is only in the Hebrew language, the HMO, Maccabi HMO worked with one of the doctors here at Sheba on one, Daniel, you might want to jump into this one, worked with them in researching hydroxychloroquine, and based on this HMO's research, hydroxychloroquine showed no improvement in severely ill patients. Are you familiar with that, Danny?
I am, and I think you know, as a scientist, you have to remain open-minded, and you just go with the data. You don't have any preconceived ideas, political or not. And I think the balance of all the studies I've seen so far is that hydroxychloroquine does not add much in terms of beneficial clinical outcome. So far.
Yeah, it's funny because there was a hospital up north that had about 70-something patients, corona patients, and they claimed that hydroxychloroquine did have some improvement, but I would surmise that 70 patients is not exactly enough to do enough research.
I think what this episode has shown is the importance of carefully, randomly controlled clinical trials that are powered at a sufficient level to interpret the data. And what you need are, in this instance, more than 70 people to get an interpreted data. It's simply down to statistics at a certain point.
How many people do you think, Neil, are needed, not Neil, I'm sorry, Professor Dweck, I would like to know, within the realm that Sheba is now involved, of course, with several of the pharma companies and some of these clinical trials, what does it take in terms of research? How many people are really needed to get a real beat on the fact if something is really working or not? That Sheba is working with several pharma companies on some of these clinical trials. I mean, yeah. I think the media would be interested to understand really what does it take to get an accurate, because there's a lot of disinformation out there in the media. There are a lot of,
you know, you need good statistics, and it all depends on events. And in people who are ventilated, you know, a very, very high percentage of those will die. So you have a lot of measurable events. So if you have a therapeutic intervention and you get a good signal from that therapeutic intervention, potentially you need fewer people in order to achieve statistical significance. So it's simply down to statistics, and it depends on the type of disease that you are trying to modify, whether it's a mild disease which affects a lot of people, or whether it's severe disease which affects fewer people, but the clinical endpoints in terms of mortality are higher. So, you know, those are not, what I want you to go away with, and what I want you to understand, these are things that you don't need to guess, okay? You can measure these things, and there are very, very talented biostatisticians who can tell you exactly how many people you will need in your study for it to be powered to have an outcome that you can interpret.
Okay, and during the course, we know here at Sheba that our Director General called it a ceasefire right now in battling Corona. I agree with him wholeheartedly based on the amount of media requests that I got during the last few months. But I'd be curious to know if these next few months that are being used obviously for research and development, if we might have, let's say by September, at least from in this country, an idea of where we're going and what kinds of treatments might work or might not work, because you will be in the middle of all that and analyzing all that data.
So I didn't hear your question in that. I had
the question is that the next few months, obviously, you know, since we started with Corona here in February, yeah. And the numbers peaked in April, we've had what, 16,500 Corona patients. Do you think that's enough during the course of the summertime for everyone who's researching this, whether it's at Sheba, other hospitals, to get a beat on what type of proper treatments might be used when a second wave hits?
No, two reasons. A, it's never enough. You know, biology is very complicated, and there's a lot more that we need to do. And you design your experiments as your results come in. So that informs the path that you take in terms of research. So that's why we're collecting as many samples as we can. And again, I'll echo what Dr. Fauci said, was that we have to be humble. This is a virus, a new virus. We don't understand it. We don't understand its course. Almost all the epidemiologists I've spoken to, and I'm not one, so I go to the experts, suggest that this virus will do what other viruses do, and there'll be a second wave. The extent of that second wave, when it'll begin, I can't possibly begin to answer that question. So we need to continue to make these measurements on people who've recovered so that we're prepared in case there's a second wave. And maybe not a second wave of this pandemic, but we need to be prepared. This is teaching us a lot about what we need to do for the next pandemic, another virus, which will come.
Yeah, that you just hit the nail on the head, is that it seems that no one really was prepared, even though the coronavirus has been around for a long time. This caught everybody by surprise. So you think that this will be the ultimate wake-up call, not just for Israel, but for everyone around the world to prepare for the next pandemic, which might happen sooner rather than later.
I hope so, but if I may, I'll disagree with one of your points. Some people were prepared, and those were a lot of the scientists. And the fact that the Vaccine Research Center, where I work, remarkable investigators there, managed to go from the sequence of the virus being published to a vaccine in an arm of a human being in the phase 1 trial within 65 days is absolutely remarkable. And that came on the back of decades of work on how to prepare making a vaccine for a potential pandemic. So among scientists, there's been a lot of preparedness, and it puts us in a good position, and we can always improve on that.
Well, I think that's something that a lot of people like myself, or even in the media, were unaware that the scientists were ready for this. You said that from the time they had that information to getting the clinical trial phase 1 in 65 days, that's pretty remarkable.
I wouldn't say ready for this. I would say learning about how to make a vaccine, learning about the immunology that works against these viruses, learning about what to target on these viruses. So setting the groundwork so that we were prepared.
That's very interesting. Thank you, Professor Dweck. Neil, going forward with your technology, what have you learned so far, and where do you think that you can actually make the technology better and better and better as the challenges present themselves?
Yeah, so there's always room for improvement. We've advanced towards surpassing human performance under the normal conditions for facial recognition. I think the key to understanding what this does is that it's an empowering and enabling piece of software, and the key is also being able to build that into other systems and other infrastructure, so that can unlock basically securer and systems which operate to provide the information that allows people to make better decisions. One example that's arisen is that we're moving into a contactless world to a certain extent. That's where a lot of fear and anxiety will be around things you have to touch on a daily basis. And we really see that, by embedding the kind of recognition that we're showing in Sheba, that, safely, quickly, and powerfully, seamless access can be provided, build up of people in crowded places can be prevented, in access to hospitals and businesses. And to take an example of how this might work also in the medical world, people going to see their doctors, their records could be securely linked to their facial profile, preventing access to records that are private to unauthorized people, preventing mistakes in names, and just generally providing a smoother and more efficient way to see clinicians. And I think these would go a long way to alleviating people's concerns about, when I need to go to the hospital, will I be able to do it in a way that can maintain not just my safety in terms of spreading germs and picking them up, but also in terms of making sure I don't pass things on to others. So I think there's a long way to run with this, and what we learn within Sheba is really how we work with the staff to ensure that it provides the right information, and how we build trust with the public also, so that we move in harmony with what people are ready for.
I think also what one would discover here at Sheba is that we are a microcosm of Israeli society, and that we have people from all walks of life, and from Jews, Arabs, Druze, Circassians, people from all types of religious affiliations, people of all ages that have come through here in dealing with the corona challenge, from a 9-year-old child with corona to the average person who unfortunately passed away, who was over 80 statistically. So we're working on a large body of work, and Yana is out there asking about, could I have several press conferences? Like I said at the top of the broadcast, is that there is enough information out there, and those people who are tuned in today who would like to do outreach to AnyVision and to Professor Dweck can do that through me. I'd be more than happy to do so. If you want more information, there is plenty of information, from the fact that that there was a story out there about the strange, and Professor Douek would be interested in hearing this, about the strange symptoms that have been found in children in the United States and in the UK that mimic Kawasaki syndrome, that ended up in a 26-year-old patient that is in critical condition here on an ECMO machine. I spoke to Professor Galia Rahav, who is the head of our department in dealing with these types of strange diseases within the realm of corona. And she said that even though the person is still on ECMO, the 26-year-old, there is a slight improvement in his health. We hope that he's young enough to come through this. This is something of a new mystery to us here at Sheba. There are 2 other patients like that in Israel. He happens to be the oldest, but it seems to manifest itself in children. Yet this 26-year-old has it, and we're working to find out what this type of mystery is. I mean, last week, if you want to clue in everyone, from our frontline corona doctors, Dr. Gadi Segel and Dr. Itai Pesach, we had a webinar earlier this week, a select group of people in Canada, that if you go onto our Facebook page, you will be able to actually hear what they had to say about all of these things that Sheba's been dealing with in terms of the challenges ahead for corona and what they discovered over time. So log on to that through Sheba's English language Facebook page, and you'll be able to hear things that you didn't hear today. I would like to say thank you to Uri Dromi, who gave us this opportunity. I'd like to thank Professor Dweck and Neil Robertson. I think those of you who want to learn more about what Sheba is doing through these technologies and through our research, I'm more than happy to reach out to me. I'm always available. And yes, there will be more information emanating from Sheba in the coming days about new things that we're doing here, from launching into space that has nothing to do with COVID-19, but does have an indirect effect on what we're doing in terms of studying viruses. So those of you who know how to reach out to me, please do so. And again, thank you, Uri, for this opportunity, and we hope to meet each other again soon.
Thank you so much, Steve, for putting this together and for running it so in a wonderful way. I want to thank Professor Dweck, Neil Robertson, our own Raya Koval and Rachel Exil, and stay tuned to our next webinar on Wednesday, 4 p.m. With the people of the Jerusalem Institute for Israel Studies, with new data on Jerusalem on the eve of Jerusalem Day. Thank you very much for you guys for being with us.